Good morning, everyone. Welcome to the first session of this conference. This is an innovative combined track of heart failure and interventions, kind of emerging field in cardiology. I'm Maya Guglin, this is Marwan Jumean, and we're going to co-moderate this session. And let us welcome the panelists here.
Awesome. So we can start. Can you please just introduce yourself to the audience? And
Hi, everyone. My name is Manreet. I'm a heart failure cardiologist at Aghili General Hospital in Pittsburgh, Pennsylvania.
Good morning. Rohit, Amin. Unique interventional cardiology and heart failure, did 2 separate fellowships. Practice in Pensacola, Florida.
Rachna, Khataria. Nice to see everyone. I'm also a heart failure cardiologist at Brown University, Providence, Rhode Island.
Charlie Resor. I'm the director of the Structural Heart Program at Tufts Medical Center in Boston.
So we have a great panel, and let me introduce our first speaker, who basically doesn't need the introduction, but I will do it anyway because it is my honor. Navin Kapur, leader in this field. Leader of the cardiogenic shock working group, professor at Tufts Medical School, Tufts University, and he's going to do the first presentation of this meeting, State of the Art, Interventional Heart Failure.
So welcome everybody to the first time that we're doing an interventional heart failure track at CVI. I've been coming to CVI for probably the last 5 years or so. And it's becoming more apparent that in all of the cases that you see in every track, you're talking about patients with heart failure, low EF, preserved EF, coming in decompensated, cardiogenic shock. It's penetrating all the tracks. So finally, Mano and the team basically said, hey, listen, I think we need a separate track. So when we built this track, I decided to populate it with some of the most unique mutations in the interventional field, people who are hybridized in their training, either interventional critical care, interventional heart failure. You're also going to see some really profound, great structural interventionalists here, and also advanced heart failure transplant physicians. So that really represents the heart team, and a lot of the cases you're going to see are going to illustrate why we have a heart team and why this track, represents a unique patient population. So I'll start by basically just giving you guys a sense of why interventional and heart failure. So actually, when I started thinking about combining the two training pathways, it all came together when Joe Lascalzo, who's an preeminent physician at the Brigham, came and visited us at Johns Hopkins and gave a phenomenal lecture to the fellows. And he talked about the 5 Ps of success in academic cardiovascular medicine: patient-centeredness, persistence, patience, practice. And then he said a word I had never heard before: perspicacity. And as a Hopkins fellow, I felt like an idiot. I had to go look this up. We didn't have iPhones that could have a dictionary there. So I went and looked this up, and what it really meant and means is basically penetration of thought, meaning that you become a domain expert with thorough knowledge in a particular field. And I was really focused on being an interventionalist, but I realized that in order to be the best interventionalist, I have to understand my patient population really well. And at Hopkins, we were seeing more and more heart failure patients come into the cath lab. And that's when I realized that these are 2 completely different languages. And so combining the 2 tracks was really, for me, just a way of hitting that 5th P that Joe Lascalzo had challenged us with. And then this is a really nice figure that was put together by Miguel Alvarez, who's also IHF trained, basically a review and looking at sort of the national number of interventional heart failure specialists, what they do in their clinical practice. If you're interested in the field, this review really pulls it together very nicely. But I think it's also important to recognize that heart failure is a pandemic. Right now it affects over 56 million individuals worldwide. This is a massive problem for humanity. And what we're seeing is that the distribution of these cases, primarily not only in developed countries, but also in emerging countries as well, in terms of the amount of patients, especially in the high volume countries like China, India, we're starting to see more and more heart failure burden. The reason why this is critically important is that global heart failure expenditures are right now in excess of $108 billion. And so when you look at the different subtypes of heart failure, they're now beginning to start to become more granular, HFpEF, heart failure with mid-range EF and heart failure reduced EF. Right now, 56 million cases, mortality ranges between 45 to 75% for 5 years, and also the morbidity is really one of the major issues for this patient population, and the costs are really significant. And when you look at some of the most recent data, this is from Nature Reviews in 2024, there's a sobering increase in US age-adjusted mortality rates for patients with heart failure, whether it's men or women. We're starting to see those numbers tick up. And the reason why that's critically important for a meeting like this is that there's an absolute evolution in the use of guideline-directed medical therapy. We're seeing great trials come out showing that there's benefits of drug-based therapies, but despite that, we're still starting to see this uptick in mortality. And so that's where this question of device versus drug-based approaches for these patients, starts to come front and center. And as you look at the evolving language of heart failure, this is also changing quite a bit. The concept of heart failure staging, and then looking at the subtypes of heart failure, new onset, resolution of symptoms, persistent or worsening heart failure. For each of those categories, B, C, and D, you can start to subcategorize your patient into one of those 4 boxes. So it's important for the interventional community to think about these patients because, frankly, you're starting to take care of all 4 stages in the cath lab. You're also beginning to see all 4 subtypes within those stages in the cath lab. And the question is, how do you optimally manage these patients if you don't speak the language of heart failure? And so that's what we're going to really focus on is this heart team-based approach today. One of the important things to recognize if you're an interventionalist and you're unfortunate enough to do heart failure service, you'll experience what I call the inpatient rock garden. Patients come in congested and they sit for 2 weeks on end trying to diurese, trying to decongest, and it takes forever. And the guidelines are really limited in terms of what you can offer these patients. It's really just adding more and more diuretics. So there has to be an intervention at some point that starts to optimize care for these patients. And in this paper that just came out in JACC Heart Failure, when they look at the modifiable and non-modifiable variables to optimize decongestion for these patients in the rock garden, you can see that actually in the red at the bottom, these are the things that you really can't modify very well. And so these are worsening renal function, inotrope use, and this is where things like support strategies and device-based approaches might help. And if you look at what does help, length of stay greater than 7 days. So basically leaving your patient in the hospital to marinate in diuretics and try to get them to diurese in the rock garden for as long as possible is what is basically showing potentially benefit. The problem with that approach is when you look at the economics. It's $20,000 basically for each heart failure hospitalization. The length of stay starts to drive that significantly. And you can see the mean length of stay is approaching that 4 to 7 days, but the vast majority of patients are not staying in that 4 to 7 day window. They're staying longer, or they're staying shorter, and they're basically leaving the hospital in a persistently congested state. So this is something that I think is a sobering contributor to the massive cost and healthcare burden of heart failure. And that's, again, where the device-based approaches come into play. One thing that's important to recognize for all of us as interventionalists is that every interventionalist is a hemodynamic specialist. Whether you like to think you are or you're not, you are a heart failure specialist. And that's because our platform, our foundation for decision-making is driven by hemodynamics. Whether it's acute MI, whether it's dilated myopathy, we're still thinking about the same physiology. And so in the sessions today, you're going to hear about a number of transcatheter-based interventional therapies for heart failure. A lot of them are going to fit into the structural domain. Some will be in the coronary domain. Some will be in the vascular domain. There'll be a lot of discussion about mechanical support and how that's beginning to penetrate into the cath lab, especially for cardiogenic shock. On the right side are some of the challenges with the physiology when you start to think about cardio-renal interaction, and that's where there's potentially more opportunity should there be a field of interventional nephrology as we start to think about more and more optimized ways of targeting the kidney for these patients with heart failure. And the reason I say that is that all paths point towards optimizing cardio-renal function. If you think of virtually 80% of drugs for heart failure that are GDMT and have great outcomes in terms of clinical trials, they don't target the heart, they all target the kidney. And so are we looking at the wrong target as interventionalists? Or should we start to be thinking about cardio-renal and more specifically renal aspects and renal interventions? And I think that's a new place for us to go. And again, even in the device-based spaces, the emerging technologies are all focused on cardio-renal function in heart failure. How do you optimize renal venous decompression? How do you optimize renal perfusion on the arterial side? And so these are some of the things that I think are going to become more and more eminent. And for the interventionalists here, one of the reasons that I think training in interventional heart failure is it makes you think very differently. For us, putting in an SVC balloon and occluding that to try to reduce cardiac preload in patients with EF of 10% to optimize cardiorenal function, to me was a no-brainer. But obviously, with a lot of work, this is now emerging as a technology. And I think as operators, this is really an opportunity to innovate when you start to think about where are the opportunities, what's going to happen in the next 5, 10, 20 years in the field, especially for those 56 million patients and that $108 billion that's being spent. One thing that's really important to keep in mind is the thin red line. The thin red line between decompensated heart failure and advanced heart failure. This line is becoming more and more blurry as time goes on. The normotensive hypoperfusing patient who gets admitted from clinic, half the time we don't check even a lactate, but these patients are hypoperfusing. And what happens to them? We know that 90% of those patients with elevated lactate will deteriorate into worsening condition before they improve. So that's something to keep in mind as we start to think about that transition towards shock. Now, we run the cardiogenic shock working group, and what we've learned is that within the first 6 hours of admissions for heart failure patients, they're starting to stratify themselves based on their phenotype and also based on their SCAI stage. And we see that a lot of patients who are admitted with hypoperfusion heart failure will start to deteriorate in those first 6 hours. And so what is the intervention that's being done? Is it a door-to-diuretic strategy? Is it a door-to-assessment strategy? And then what happens to the 50% of patients who don't improve in those first 6 to 72 hours? How do we manage those patients? And that's, again, contributing to the inpatient rock garden, which actually can be deadly for a lot of patients. Now, one of the reasons why I think interventional heart failure has taken off and there's a lot of interest in it is because we learn from the heart failure side all about VAD physiology. When you think about mechanical support as an interventional heart failure person or as a heart failure person, you're thinking in terms of LVAD function. But all the fundamental principles of an LVAD, the HQ curve, afterload dependence, preload dependence, those are all completely relevant to all of our percutaneous MCS support strategies. So to optimize our percutaneous MCS approaches, we really have to have a fundamental understanding of physiology. And this is becoming more apparent now as the Impella platform starts to grow in its utilization and more platforms come onto the scene. The Impella 5.5, for example, teaches us an immense amount about its impact as a left-sided support device on biventricular function. And as interventional heart failure folks today, you're going to hear about advanced hemodynamic techniques and how to implement those techniques in your practice to optimize patient outcomes. So we started the interventional heart failure training program at Tufts Medical Center back in 2011. This is the way the curriculum works. Our fellows do 12 months of advanced heart failure transplant training, followed by interventional training, which includes structural exposure, a significant amount of structural exposure during those 12 months. And the goal is for these folks to be dual board certified. And primarily the majority of them sit in cath labs as interventionalists who can now interface with the advanced heart failure physicians and speak the same language for these critically ill patients. These are the alumni, so this looks like the CVI track for IHF today because we invited almost all of our interventional heart failure alumni to join us today, and a good majority of them were able to join. But if you read Miguel's paper, it's really important to notice that the different practices that they're in. Some are in interventional private practice, some are interventional heart failure faculty at some very preeminent universities, and so there's a really interesting penetration of how they are in clinical practice and what they're doing with their training. So I'll stop there and we'll kick off a great session for interventional heart failure. Please engage with lots of questions. It's a really important topic for our patients and for our clinicians. Thanks so much. Discussion, or do you want to continue and then do discussion again? Your choice.
You can just ask.
Let's open it for questions. Panelists and audience, everybody is welcome.
So Navin, you spoke about the cross-training between, well, not cross-training, additional training for heart failure and interventional cardiology at your program. And the fact of the matter is nationwide heart failure fellowship is not the, we have 50% vacant spots. It's not getting any better. Do you think that we need to be thinking about, training within interventional, not maybe as an additional year, because less and less physicians want to be in clinics, more and more folks want to be shock doctors, shift work, go home, not have to think about it. So do you think it's time, even taking a step back in the general cardiology fellowship, to not necessarily separate them out as we have, so that we all speak a little bit of, that language?
Yeah. No, it's a great question. And I think the way to think about this is to actually talk to a lot of the candidates who are struggling to figure out what to do. And I'd say at least a few times a month I talk to a fellow who's interested in interventional heart failure training. I'd say half the time the question I ask them is, if you had to choose one and you could only choose one, which one would it be? And that really helps us start to figure out which path they're primarily focused on, where their passion lies. And I think the frustration, with a lot of the folks who want to do heart failure is the clinical practice itself. It's not an easy practice. It's not well reimbursed in many ways. And also the frustration of not being able to make decisions and then act upon those decisions yourself. Now, having said that, I think it can be ambitious to try to then do interventional training. Interventional training is changing radically. I'd love to hear from Charlie about the trajectory of structural versus coronary. And for folks to train specifically in just MCS alone, is not really a viable pathway. The complexities of vascular management, et cetera, doesn't quite make sense. So I think in order to optimize care for our patients going forward, I would envision that there's going to be more hybridization of training. It's going to be not just interventional, but I think it'll be more of a heart failure critical care or a pathway within heart failure where you can actually start to intervene and optimize management of your patients, whether it's in the cath lab or outside the cath lab. It's also important to recognize that there's also invasive cardiologists who are trained in advanced heart failure. There's more than enough cases to do in the cath lab that are diagnostic, that are all of the hemodynamic studies, the RAMP studies, the HFpEF studies. They really accumulate very quickly. And so the importance of an invasive hemodynamicist who's also a heart failure specialist, I think is as equally important as the interventionalist. But I'd be curious to hear what people think. And in fact, we'll just poll the audience now. So how many folks here are actually dual trained in interventional and heart failure? Okay, so a fair number. And then how many folks here are trained in heart failure? Okay, and how many here are interventional? Okay, great. And then there's some who are none of the above. And then for the heart failure physicians, how many of you are implanting MCS devices? Great. So I think you can start to see that there's a spread. And my advice to the heart failure leaders is to essentially start to adapt their practices. I think the outpatient-based practice can be run primarily by mid-level providers. They do a much better job, and it starts to free the heart failure physicians up to do other more critically ill patient care.
One more thing is one of the challenges. So we run also at UT an interventional heart failure fellowship, but it's designed for the interventionalists. So and you finish interventional training and then you go to do specific aspects of heart failure, not everything. So it does not allow you to sit for the heart failure boards because you're not doing everything. You're spending most of the time in the ICU or in the cath lab. The challenges are a lot of people don't want to do that. Number one. Number two, after 15 years of training, oh my God, I'm going to do another year of training. I don't want to do that anymore. So that's one of the challenges. Before I give it up to my panelists, I have one question for you, which is, I think you mentioned this. I think the stability of the hemodynamic circulation is evident by renal function. And if the kidneys are happy, then I think the hemodynamically you're okay. The question is defining time. Time to recognize patients who are in shock, time to support them adequately is something that is poorly understood, because when you look at a patient, you look as, oh, this patient's in shock. It may be different than when I look at them or when a trainee looks at them, and I think that delays the diagnosis. And then your approach to this patient is different than my approach to this patient or my co-monitor's approach to this patient. So there are a lot of challenges within that. It's not clear-cut like a STEMI patient. And I think this is what we need to focus on as interventional heart failure cardiologists is time to identify and time to appropriately manage those patients, I think is a challenge moving forward.
No, I think you're right. And I think this is critically important. I think the idea of decongesting and getting optimal hemodynamic stabilization, the strong HF trial just came out in publication format, and they waited 72 hours to enroll those patients until they were quote-unquote hemodynamically stable. But during those 72 hours, many of those patients didn't get to the point where they were candidates for strong HF, for optimal GDMT therapy. So there is that window of opportunity. The challenge right now, and this is where I think participating in CVI, seeing some of the emerging technologies, and getting involved in those trials is really important, because the FDA, for example, right now still defines successful decongestion based on urine output. And that is a signal that's very difficult to track. It has no correlation with hard clinical endpoints. And your patient may be peeing, but if they're still massively congested in a low output state, they're going to eventually stop peeing. And so this idea of being able to intervene early, hinges very clearly on our language and how we define that decompensated patient. So that's a really important aspect of the care right now.
If I might have another question, for those that are fellowship trained in interventional heart failure, how many of you practice in a community non-university based position? Okay, so in your practice, do you have a dedicated heart failure doctor as well? Yeah, so similar to my position as well, it's very challenging, very demanding as you get appointed as that individual that's trying to manage both interventional and complex advanced heart failure patients. One of the things that to keep in mind is obviously we are at a position where there's significant crossroads in both complex coronary disease, structural heart failure management. Having the ability to have one individual be at that table for discussion piece, particularly when you're trying to decide on which patient needs ECMO or shock upgrade, or even in situations where you have a patient who has advanced CAD with compromised LV function. I've seen a number of cases where you have a heart multidisciplinary discussion, and because the patient's ejection fraction was 15-20% and the patient's renal function was compromised, those patients typically get no adequate therapy at all. And if you're in a community situation, you don't have a VAD center and you don't have a transplant center, you actually do jeopardize those chances for those individuals. So my point is, for any of the interventional cardiologists in the room are thinking about potentially foraying into this space, HFSA has now provided a nice little pathway. It's called the HFSA Specialist Heart Failure Pathway. So you don't have to go back to formal training. You do have to demonstrate some proficiency and competency in your clinical practice where you're managing advanced heart failure patients. There is a core curriculum and a board exam, I believe, to take for those individuals. So for any of those interventional cardiologists that may be interested in that, I think that would be a great opportunity as well.
Perfect, thank you.
Great point, Rohit. So let's proceed to the first case. It is a biventricular transcatheter end-to-end repair or transplant, going to be presented by Charles Resor. Am I saying it correctly?
Yeah, that's correct. Thank you.
Good, from Tufts.
So I'm Charlie Resor. I'm the director of the Structural Heart Disease Program at Tufts Medical Center in Boston, and I'll be discussing biventricular transcatheter edge-to-edge repair, or in advanced heart failure, TEER or transplant. I'd like to thank CVI for the opportunity to speak here today, and I think we'd all like to say thank you to Navin for sort of establishing and defining this field of interventional heart failure, in which we're all very fortunate to work. So thank you, Navin. These are my disclosures, and just as sort of a point of clarification, I'll be using the terms TEER and CLIP sort of interchangeably throughout this talk. So as the field of TEER and advanced heart failure is still in its infancy, there's an enormous gulf between the data that we have and the data that we want. We'd obviously love to have a better epidemiological understanding of valve disease in advanced heart failure patients. We wish we had randomized trials of devices in these patients, and we wish we had a better body of evidence and literature from which to derive treatment algorithms and guidelines. In reality, these are not patients that lend themselves well to randomized study, so we're left to extrapolate from other randomized trials, such as subsets of COAPT or subsets of Triluminate. And then probably the largest body of evidence we have is non-randomized data, some of which I'll discuss here today. Everybody in this room is familiar with the COAPT results. I won't belabor them here. I'll just remind everybody that in patients with HFrEF and severe MR, MitraClip resulted in an absolute risk reduction for mortality of 17%, which leads to a number needed to treat to prevent mortality of 6 over 2 years, which I would put to you as one of the most successful or effective mortality preventing therapies we have in all of medicine. While it was not specifically an advanced heart failure trial, MitraClip did result in a decreased use or implementation of LVAD or heart transplant in patients in the treatment arm. And while this was not necessarily an advanced heart failure population, I would put to you that with a control arm that had a 50% mortality rate at 2 years, these outcomes are not dissimilar from those of patients with advanced heart failure. That said, most of the patients in whom we get asked to evaluate for CLIPS with advanced heart failure fall outside the COAPT criteria. And for guidance on those patients, we need to look to non-randomized studies such as the MITRA Bridge registry, which you see here. MITRA Bridge was a multi-center international registry of patients being evaluated for heart transplant who, for one reason or another, were felt to have a long time between evaluation and eventual listing. These were all felt to be patients who were good anatomic candidates for MITRA clips. So all patients were treated with a clip, and then they were grouped into sort of three different buckets. Patients who were actively listed, but were going to have a long time before they would receive a heart. Patients who were considered bridge to decision, which is patients who needed more time for testing or more time before a decision on their candidacy could be made, and then patients who were considered bridge to candidacy. This was patients who had a potentially reversible condition like pulmonary hypertension that would need to improve before they could be listed for transplant. The average Intermax score was slightly greater than 3. All patients were treated with a clip, and the study now has 2-year outcomes to report. So despite a very sick patient population, there was a 0% 30-day mortality with the MitraClip procedure and a nearly 90% technical success rate. The primary endpoint was a composite of death, urgent transplant, and heart failure hospitalization, which was met by about 50% of patients in the trial, or study rather, but driven mostly by heart failure hospitalization. Interestingly, 16% of patients who were not previously able to be listed derived enough clinical improvement to get listed for transplant, and 23% of patients who were previously listed improved enough to the point that they're not felt to require transplant, at least over the 2-year follow-up period. Now, obviously, this study doesn't have a comparator arm, but I think it's suggestive that MitraClip is at least a safe strategy in these patients and a potentially effective one in patients who are not going to be getting a heart anytime soon. And the authors of the study will point out that these patients did better than historical controls for what that's worth. So for our clinical presentation, our patient was a 55-year-old man with a non-ischemic cardiomyopathy with an EF of 15 to 20%, severe MR and TR, and a primary prevention ICD lead in place just to make the tricuspid aspect of the procedure more challenging. He'd had multiple admissions for heart failure in the last year, was on a decent medical regimen, and he was not being evaluated for transplant because of extensive social or compliance issues, but I think otherwise would have been. He had class 3 heart failure. So you can see his baseline echo here. He's got a severely dilated LV, very reduced EF, severe MR, pacing wire on the right side, and then severe TR. This is our intraprocedural echo. You see severe MR on the top left panel. This is us getting our clip sort of oriented a little better. And then the panel on the top right, panel on the top right is showing us, my apologies. Moderate residual MR after one clip was deployed. Here's our second clip being delivered. Oh, there was our second clip being delivered. All right, sorry. I'll show you the follow-up shot after that, but the patient had minimal residual MR after the second clip was deployed. Now we're onto the tricuspid side where you can see things are a lot more challenging. Top left panel shows our transgastric view with the pacing lead flopping in and out of the picture, which obviously makes life more complicated. Middle panel is us getting a little bit better orientation and getting our clip lined up, and then the bottom panel here is us with our grasping view. This is now with the clip attached and not yet deployed. We now have probably moderate plus residual TR, but this procedure was done before the tri-clip was actually released, and so the old MitraClip was very challenging to steer down to the tricuspid position, and so we felt with a pacing wire on one side, one clip deployed, this was a more than acceptable result for TR reduction. This is the result on the mitral side, which I think shows pretty minimal residual MR, and these are the results that we're sort of used to getting now in the mitral position. On the tricuspid side, sorry that didn't play, but I think you see, I'll try to show you that, at least moderate, maybe more residual TR here, but again, with the limitations described with the old device and the pacing wire, I think that's a pretty decent result. So in clinical follow-up, the patient felt better. His NYHA class improved. For what it's worth, he got about a 30-point improvement in his KCCQ score, though those are obviously somewhat subjective. And he had fewer admissions for heart failure in his subsequent 9 months of follow-up. I think there's now a growing body of evidence, non-randomized, to show that MitraClip in patients who are not COAPT candidates is safe and, again, in non-randomized fashion, potentially effective with regard to improvements in NYHA class and KCCQ score. I think MitraClip is starting to work its way into certain algorithms for patients with advanced heart failure. I do think, at least at our center, if patients have been evaluated for a transplant but are not going to get a heart, they're great candidates for a clip because they have little else to offer them, and this is something that's safe and effective. And even for patients who are starting their transplant listing are probably going to wait a while for a heart but feel terrible and need something done, this is something that you can offer patients. Obviously, the sicker patients who are closer to getting a heart, I don't know that there's much role for a clip, but for everybody else, I think it's a reasonable consideration. So I'll stop here and take questions. Thank you.
Perfect. I do have a question. So the last slide that showed the algorithm, it's still based on symptoms. So their Intermax, NYHA class. There's nothing subjective. So if I see a patient in clinic who's relatively okay on some GDMT, LV 6.5 centimeters, there's severe functional MR, what's the value of doing CPET or invasive hemodynamics to see where this patient falls before I say I'm going to do an TEER versus refer this patient for advanced therapies? And what's the this is now 5 years from now we're going to have 3 other devices that looking at coronary sinus, this and that can potentially help those patients before we get to the LVAD. So where do we get that in the decision tree making?
Can I add to that question? Because it was interesting to see that the MR and TR were both taken care of in the same setting. So again, when you're evaluating, and if you are, is there any consideration for like a stepwise approach? Because could that TR improve as the MR improves?
Absolutely, those are great questions. I think to the first question, I think a lot of that remains to be elucidated. For us, I think a lot of our decision making is guided by how long we think it is before this patient gets a heart. If it's going to be years, then I think this is something we have to offer people to make them feel better. For the sicker inpatients, who are struggling to get out of the hospital and they're going to be able to get transplanted soon, I think we just go straight to a transplant. With regard to what we do, we now would choose a stepwise fashion, mitral first, and then see the tricuspid improve. I think in the old days, practically speaking, probably shouldn't talk about off-label uses, but in the old days, you couldn't get reimbursed for a tricuspid clip, and so you had to do them at the same time. Now it's an on-label procedure, and so you get reimbursed for both, so you can split them up, which is much preferable for the patient clinically and for the operator. But it was really a practical issue, really.
And would you consider a clip to get a patient out of cardiogenic shock?
Yeah, that's a great question we get asked a lot. I think if it's the only option that they have and that's what you got, I think you have to offer it. I think if that patient is getting put on ECMO and is going to get a heart soon, then we would say that's obviously the best thing for the patient. But for patients who are not candidates and you think what's standing between them and getting off the vent is their severe MR, we do, just with the caveat that there's a sick patient, the outcomes may not be quite as good as we're used to.
Thanks. I'll add to a couple points. There's so much to unpack there. In my opinion, that's probably the quintessential example of why interventional heart failure should exist. There's nothing else in a real-life example other than cardiogenic shock, managing a patient with advanced heart failure, either proportionate or disproportionate MR, LVEDT more than 6, you're in a community setting, the patient has to travel 300 miles to get a transplant evaluation, they don't have the luxury of being in a university setting, what do you do? So on the interventional side, who don't have heart failure background, if you look at the Abbott criteria, EF less than 20%, they're contraindicated in the COAPT trial. The reason why COAPT trial MITRA-FR was inconsistent was because when you looked at really the data, a lot of those patients has disproportionate MR. And so when you're starting to really look at these detailed examples of these patients, it's really incredibly important to have maybe an advanced heart failure patient also know mitral data, just like the interventional guy who speaks with the surgeon on a structural heart discussion about MR, what is the best approach for that particular patient. Second, that particular patient that you had exceptionally good results with one clip. Oftentimes in functional MR, there's really one concern is afterload mismatch. And the more concern will be when we start doing tricuspid clip. RV is not built like the LV, like many of you guys know. Surprisingly, though, even in the advanced heart failure patients that we do perform mitral clip, they actually do pretty well, and most of them get discharged the next day. We're realizing now with tricuspid, it's a different game. Those patients that actually come in earlier, be diuresed, so you can close the capitation gap, and we put them on diuretics for the next day or two. So again, another opportunity, a quintessential example where I think the two fields can intersect, but having a heart failure physician on that structural, particularly functional MR team is incredibly important to look at besides the specific details.
So Charles, the title of your presentation was age-to-age repair versus transplant, and the case is brilliant. From your own experience or from the literature, by how much can you delay the transplant? Or it is like transplant is completely off the table, or is it, do any data exist on it?
Yeah, no, I think that's a great question. I think, are we, and the other question would be, are we even, if you delay someone's transplant, are you actually doing them a favor? You know, it was not the best thing perhaps just to get them the heart, which is the definitive therapy. I think, you know, in our center, I think we look at it less as TEER or transplant and more of a yes to both sort of approach. I think for people who can get a heart soon, the heart's probably the best thing for them. But I think practically speaking, most of the people who get evaluated are not getting a heart anytime soon, and those are the people who need something. And then I think for everyone who actually does get listed, there's probably an even wider or greater population of people who don't end up getting listed, and those are people who are definitely great candidates for the procedure.
Can I add a question and a comment on that? I think I have a heart failure question, and then I have an interventional question. So I think I always thought, like you, Marwan, that there should be a role of objective CPET assessment before and after these procedures. And also, we should use this type of therapy to within UNOS criteria. Like you should be able to get UNOS status 4 if you have bilateral TEER, something like that. The same listing criteria that if you have a VAD, because you don't want to delay definitive therapy, but you're trying to buy certain time for the patient without withholding actual transplantation. And then from the interventional perspective, how do you balance, you know, TVT reporting outcomes? You know, these are sick patients that not necessarily will be around in a year. We know those reporting outcomes are very important, especially in TEER. And also, are you using ICE for this bilateral TEER cases?
Yeah, in terms of the outcomes, I think you have to have a certain volume of cases, you know, before you can start offering the cardiogenic shock, you know, patients a clip at your center, or else you'll be, you know, an early mortality will dominate your outcomes for 3 years, you know, in the TVT registry. But I think it's, you know, on the flip side, from the patient perspective, they don't care about that. And if it's the only option you have to offer people, you know, we probably ought to be offering it. I just think you have to know what's going on at your center and have enough numbers in the denominator to be able to accept some bad outcomes. And with regard to ICE, I think obviously not so much in the mitral space, but it will have a very big role in the tricuspid.
I think we have one more question from Dr. Bimaraj.
Yeah, I think to your first question, I think that speaks to the importance of having a heart failure trained doctor on the heart team. And I think we look to those, our heart failure specialists, to sort of guide us and make sure that everybody is optimized the way they ought to be and plugged in. And so we're very fortunate to have that. But I think the heart team is sort of very big on having a heart failure trained doctor on the heart team for these patients. And to the second one, I think it's a tough question to answer. I think I can understand, certainly I was much more risk averse when I was just starting out and had fewer outcomes in my denominator, and I wanted more cases to sort of balance out the bad outcomes were coming. I think really the way we look at it is if someone's going to get a heart, and they can get a heart soon because they're an inpatient, they're going to get put on ECMO. I think that's the best thing for them, because at that stage, I don't know how much the clip's going to do for them, but it's the people who are not getting a heart anytime soon. I think those are the people we probably ought to push the envelope because they have very few other options.
If I may make one last comment about very important points. I have a bit of a concern why this adoption of MitraClip has not been as robust as, for example, CRTD. If you look at the CRTD rate in the non-responder, it's incredibly low. Yet, we're always keen about doing that before transplant or VAD evaluation. Many of the patients that you think may not do well, they actually end up doing well, improving quality of life, less rehospitalizations, and in some registries have been shown to show LV reverse remodeling as well. Surprisingly, despite many of the data sets and the number to treat, we've still seen probably the lowest adoption in the transcatheter management of MitraClip than any other thing that we potentially have now. And I think a lot of it has to do with the concern about what will happen to that particular patient after MitraClip, whether immediately or long-term. And again, that behooves the point here made by the panelists is that having those discussions, and for example, in my situation where you don't have a local transplant or VAD center, I'm always thinking about those advanced heart failure patients to be sent to the referring center and then having a discussion with their cardiologist. How far or how long ago are they on the list, and do you think this is a viable option? And oftentimes that helps decide to risk stratify that particular patient.
Awesome, thank you. 10 years ago, Navin told me when I was his fellow about interventional heart failure intervening on 4 Vs. Do you remember that? And the theme of this session is 4 Vs. So intervening on initially valves. Now we're going to talk about VADs. Next session is Sandeep Nathan with vessels, and then the last is with ventricles. So the next case will be presented by Carlos Davila from Yale, talking about my LVAD is failing, now what?
Thanks, Marwan. Thanks so much for having me. It's really delightful to be here and follow Navin and Charlie, 2 of the people I learned the most from. I was asked to talk about the role of interventional heart failure in LVAD medicine. And I'll try to do this using a clinical scenario and some of the reports that we put together. Nothing to disclose. So I think it's well known that left ventricular assist devices in both bridge to transplantation and destination therapy have improved outcomes in patients with advanced heart failure population, shown in this Kaplan-Meier curve. It's with an 80% survival at 1 year and a close to 50% at 5 years. Without an LVAD, these patients will die for sure. Interestingly, over the past couple years, we've seen a change in the landscape in LVAD medicine with a significant reduction in the implant volumes over the past 3-4 years, mostly due to a combination of issues. Some of them good for the patient, some others not. The new UNOS allocation back in 2018 favoring more temporary MCS over durable MCS. Innovation of other platforms like the Impella 5.0 and 5.5. The withdrawal from the market of the HVAD system. And then also the pandemic was a significant influence in VAD volumes across the country. Moreover, and very importantly, now the strategy and the indications for LVAD implantation has changed over time, with most of the LVADs being implanted as a destination therapy, shown here in green, compared to bridge to transplantation or bridge to decision. And this is important because these are patients who are usually elderly, who have not other options, and reoperation or reduced sternotomy will be a highly morbid procedure. Despite advances in LVAD medicine, there's still the top 10 reasons for readmissions and mortality in these patients. LVAD dysfunction is one of them, around 5% of these patients based on the most recent Intermax registry. And similarly, mortality, LVAD dysfunction, it's one of the most important causes for that. And when we approach LVAD dysfunction, this should be done by a systematic and multidisciplinary approach. As people in this room know, there's intrinsic causes for LVAD dysfunction, your usual RV dysfunction, valvular heart disease, GI bleed, or hemolysis, but there are also device-related causes. And for that case, we have to interrogate or investigate every single component on an LVAD, from inflow cannula, outflow cannula, rotors, and console, in order to diagnose what's wrong with the LVAD and how to treat it. That's why having a heart team approach is so important, where advanced heart failure providers will work together with VAD transplant surgeons and with interventional cardiologists, especially those with an interest of MCS or interventional heart failure that had some understanding of LVAD medicine. And so I try to exemplify that with this case that I was involved with during training. So a 40-year-old male, blood type O with non-ischemic cardiomyopathy, had a bridge to transplant HVAD, and who came in multiple times to the hospital with acute decompensated heart failure. I've summarized some of the clinical parameters here and LVAD parameters. No significant evidence of hemolysis and coming in with significant low flow alarms. After a multidisciplinary approach, the decision was made to do a right heart catheterization. You can see the hemodynamics there. Biventricular elevated filling pressures and hemodynamics consistent with heart failure-related cardiogenic shocks, SCAI stage C. And so the decision at that point was made to put a balloon pump in. And at that point in the cath lab, we noticed an interesting feature in the HVAD console. And when we noticed, it was Navin who noticed it, that there was a lack on the inverted flow that you should see in diastole if you have a diastolic augmentation from a balloon pump. This is just for reference, and this is our patient's console. This is a picture taken from our cell phones in the cath lab that day that did not show any of the inverted flow deflection during balloon pump augmentation. And this is a cartoon showing how it should work. And so this is your LVAD here, balloon pump going up and down, and then that deflection being a representation of balloon inflation. Whereas if you have something obstructing your LVAD, you wouldn't see that deflection. So at that point, we decided to take him back to the cath lab. He was taken off the table with heart team approach, taken back to the cath lab for a hemodynamic RAM study to assess LVAD parameters at different incremental flows, which had no improvement in hemodynamics or flow parameters. So then we decided to cross the aortic valve with a dual lumen pigtail catheter or Langston catheter in order to obtain, and this right here into the LV, in order to obtain simultaneous LVAO tracings. And this is how your functional LVAD should look like. You have a regular, normal LVEDP. You have an uncoupling of the LV and AO with a non-pulsatile flow. And in this case, there was an elevated LVEDP with coupling of the LVAO and pulsatility in the AO tract, confirming the diagnosis of LVAD dysfunction. So we then did an LV gram to try to identify the outflow graft, and then the decision was made to interrogate that outflow tract. We engaged it retrograde with a multipurpose catheter and exchanged that over an 035 wire for the dual lumen pigtail that allowed us to perform a pullback, which I have a picture here. And you can see a pullback. During the pullback, there's a significant gradient of 40 millimeters of mercury at the midsection of the graft, confirming now an outflow graft obstruction. At that point, after discussing with the surgeon and our LVAD director at that time, we decided to go ahead and stent the outflow graft at the level of the occlusion. And for that, we used off-the-shelf biliary stents, bare metal stents, that were delivered over an A-French system and an 035 wire with good resolution, patient-tolerated procedure, resolution of the gradient, and resolution of low-flow alarms, and patient ultimately underwent transplantation down the road. So based on this case, we put together a case series that it was published a couple years ago and came with the algorithm of a stepwise approach of LVAD dysfunction in the cath lab. And pretty much what I just summarized. You do a comprehensive console review and paraclinical review, followed by invasive hemodynamics, a RAM study, left-sided hemodynamics, an LV-gram is possible, and lastly, an outflow interrogation. So I took the liberty of adding something to this. What if my LVAD is succeeding, right? So what if I don't need the LVAD anymore? There is another application for interventional and structural techniques in these cases. This is a case of LVAD, percutaneous LVAD decommission, and again, we used oral and invasive hemodynamics and understanding of LVAD medicine to realize that the patient didn't need the LVAD anymore, and at this point, we did a percutaneous balloon occlusion with just off-the-shelf ZMED balloons and reassess hemodynamics to confirm that the patient didn't need the LVAD anymore, followed by a percutaneous delivery of an Aplatz or vascular plug and a successful decommission of this LVAD. So cases like this and sessions like this foster the notion of this hybrid training and interventional heart failure operators, and how important it is to diversify your workforce in the cath lab. We all know we have coronary operators with peripheral train, and you'll see each room in this conference session, it's a peripheral track, it's a CTO track, it's a structural track, and now we have our MCS IHF track. The same thing should be replicated in cath labs across the nation and the world, especially if you're doing LVAD and transplantation. Some of the gaps in knowledge that I came up with in terms of LVAD in the cath lab is, I don't think we know what's a normal gradient across an outflow graph. Is it 10? Is it 5? If it's 0, is it 20? Is there any role for uplisting the patient unistatus once you develop one of these complications? The same way we do with RV dysfunction. For this particular case, there had to be a narrative and an exception submitted, and it was accepted. Is there any role for dedicated equipment for these cases? It's probably not, you're not going to be doing 2 of these a week, hopefully. So is there any role for that? And then is there any role for routine hemodynamic interrogation of these patients, especially in those who LVAD is the destination? With that, some of the take-home points, LVADs are here, they'll be around, and we need to understand what are the potential complications and how to diagnose them and treat them. Also, outflow graft obstruction is a potential lethal complication. Usually surgery is the treatment of choice, but in those patients with surgery is not an option, invasive percutaneous options are available. The importance of the heart team approach, I cannot stress that enough. And the evolving field of interventional heart failure, I think it's here to stay. Not only there's a need, but there are people like sitting in this room that are interested in it. So with that, I'm happy to take any comments or questions. Thanks.
Thank you for this great case. As the cases of pump thrombosis are going down with the dominance of HeartMate 3, we have less pump thrombosis, but the outflow graft stenosis is increasingly recognized as one of the problems for malfunction of the LVAD. This is an exquisite hemodynamical diagnosis of the case. For all practical purposes, CTA can get you to the diagnosis quicker. And it is non-invasive, and after this you can certainly do your gradient across the outflow tract of the LVAD, outflow graft of the LVAD. But otherwise, it is a great case. And I think that the question, what is the normal gradient across the LVAD outflow tract, really nobody knows the answer.
So actually, Maya, to that point, what the case Carlos showed was an intrinsic outflow graft obstruction, which is also very rare with HeartMate 3. What we're seeing with HeartMate 3 is the EOGO, the extrinsic outflow graft obstruction, which unfortunately cannot really be corrected with a stent. You have to do surgical debridement of whatever the goo or junk is stuck in there. And the twist, which was a cause of HeartMate 3 outflow graft obstruction, is no longer a thing as well. So we just yesterday did an EOGO outflow graft exchange, again, diagnosed with a CTA. We used to do all these, hemodynamic assessments ourselves, but probably no longer necessary because the pump thrombosis is so you do the traditional ramp study to see is it the pump thrombosis or not. And to your gap of knowledge, the second point, there is a pathway for upgrading them in UNOS as MCS, device complication. You may have to use an exception if it doesn't fit the usual criteria. My question to you was, I think the biggest intersection we are seeing now in the HeartMate 3 interventional cardiology world is AI, aortic insufficiency, especially late after HeartMate 3. I say HeartMate 3 because that's the only commercially available pump at this point. Could you speak a little bit to the use, if it is, again, a hemodynamically significant AI in somebody who's not transplant eligible, using TAVR and or other investigational aortic valve devices for AI?
Yeah, it's a great point. It's definitely been done. I think before there's now a dedicated platform for severe AI. It's undergoing trials. This wouldn't be a case that it's enrolled in the trial, but once it's commercially available, I think it'll definitely be done. The couples I've seen, I've been part of, we used oversized self-expanding valves over balloon expandable valves because these are severe AI cases that you worry about valve migration and whatnot. I'm sure Charlie has some experience and input on it. But yeah, it's been done and we've done a couple.
I'm going to push back a little bit on the lack of need for the cath lab assessment of those patients. Most of these patients with an LVAD probably had half of them had a prior bypass surgery before. This is a second, third redo. Sending this patient to OR without a proper hemodynamic assessment and exhaustion of everything is maybe some pushback. So I think at least for us, we'll do a CT, we'll do a 3D rendering of where the issue is, and then we'll take them to the cath lab, we'll do assessment of the hemodynamics with the right heart cath, we'll do an invasive ramp, and then we'll do interrogation of the outflow graft. And even if there's extrinsic compression, we use a Viabond instead of a biliary stent and a longer stent, so that would prevent the tooth pasting of whatever that's causing the obstruction. And then we stent it successfully. And worst case, if that fails, then we have an OR ready for backup. They'll take them to OR and they do it. But at that point, at least we've exhausted everything before we
I think for this particular case, the CATs can actually show no evidence of outflow graft obstruction. These are patients with CKD, which are minimizing contrast, so staying with pure hemodynamics, I think there's a valuable role. I agree with Marwan. Maybe we're a little bit biased, but I don't think for all the case series that we had were 5 patients and 2 of them had normal CTs and gradients across by pullback.
So you're absolutely right. What I meant to say was the most common cause of outflow graft obstruction now is the extrinsic, which unfortunately there's really not much to stent and has to be surgical. The other OGOs, of course, are still what you said we would do.
I think Arvin has a question too.
Yeah, we actually successfully stented several patients with the extrinsic obstruction. You mean this debris from Gore-Tex placement around the outflow graft, right? They can be stented, you just need longer, more durable stents.
No, congratulations on the case. I think that's excellent. I do agree that I don't think CT always gives us the answer, and there have been cases where we just live with these low-flow alarms. My practical question is, I don't think we do as many invasive testing as we have to. What precautions would you advise when you generalize this, putting in wires into the cannula and the graft not to cause harm so less skilled people like us can start doing this?
Now, let's remember these are patients who are on anticoagulation, who have non-pulsatile flow, right? So access is key, especially if you're doing afferent sheaths. So ultrasound guidance, micropuncture, you should be facile with large bore access and patients on anticoagulation for this. Also, these patients can develop aortic valve fusion, right? So you got to make sure they don't have a clot there before crossing the valve and giving them a stroke. So yeah, all your technicalities from interventional cardiology come into play here, and from structural cardiology are very important to do this safe. And that's one of my gap of knowledges there. Is there any role for routine hemodynamics on these patients who are declining over time, or you're getting low flow alarms here and there? I don't have the answer to that.
Thank you so much. Let's proceed to more traditional intervention, interventional coronary arteries. Multivessel PCI with a 10% ejection fraction. Really? So we're going to have Sandeep, Nathan, presenting.
All right, it's a pleasure to be here. Thanks for having me. I'm a little bit frontal. I've only had about 2 hours of sleep, so I apologize for that. All right, so I couldn't find anybody with a 10% EF that was referred to me, but pretty crappy EF with, on dobutamine, I think sort of fits nicely as well. Here's my disclosures. Okay, 65-year-old female with chest pain and shortness of breath for the past 4 hours before she presents. You can see the laundry list of medical comorbidities on there. I think the most significant one is that she has end-stage COPD, or severe COPD on HOMO2 intermittent steroids. HFrEF with an EF at a recent prior echo of about 25%, although you can sort of argue about that a little bit. I think the most significant comorbidity is that she's severely malnourished, and she's 31 kgs, so she's quite small. Her vasculature is small. She's, a very functional human being, but has a lot of comorbidities going into this. Of note, she's had a couple of prior recent hospitalizations, more for heart failure, although this was being billed as ACS. You can see our troponins are elevated, but not particularly impressive. I don't know what your experience is, but in our institution, after we switched to high sensitivity probably about 10 years ago, I would say half the hospital is troponin positive at any given time. So I don't really get excited about troponins until they're a couple thousand and rising. Okay, so here's on dobutamine. She ends up on the floor. She's not diuresing. She's clearly volume overloaded. And this is on about 2.5 mics of dobutamine. Regional wall motion abnormalities. Here, her EF is maybe 25 to 30%. It perked up a little bit with dobutamine, and she's doing a little bit better. Never had a diagnostic angiogram before, and this is her diagnostic angiogram. And so I think you can pretty clearly see the left main disease. You can see the CTO-LAD. You can see that there's some circ disease as well. And before the dye goes in, I think it's notable how much calcium there is. And so, it's nice to fix things, but just understand sort of what you're getting into before you get in there. And calcium modification almost has to be a part of this, which incurs, as everyone knows, potentially more ischemia going into the revascularization. RCA isn't pretty either, although the RCA is giving some collaterals through an acute marginal to the occluded LAD system. Severely calcific left main here. The circumflex was IFR positive. At the time that this diagnostic was done, hemodynamics was done as well, and confirmed that she was in fact a little bit volume overloaded, although she had made good progress by this time with dobutamine supported diuresis. And so here's all of her comorbidities here. And appropriately, surgery was consulted, but if you really sort of put objective eyes on this, her syntax score is pretty excessive. It's in excess of 50. if you have eyes to fix everything. And the added challenge here is that, every day of the week that you are asked to do something like this, you're going to ideally have mechanical circulatory support, which was sort of off the table because of her PAD and the very small vessels. The left main was IVUS at the time of the diagnostic. They threw the IVUS down there as well. And the better leg that you see here is probably about 4.5 millimeters in diameter. Not great. So CT surgery was consulted, and after they got done laughing, they put in the chart that she's at a prohibitive risk for surgery, which is, I think, the politest way to say no. I certainly don't fault them for an operative mortality. Here's the STS score. Operative mortality of 30%, and her likelihood of a protracted stay is about 50%. And so now this ends up in our court. And so, one sort of notable thing that we didn't do is get viability testing. There were reports of multiple wall motion abnormalities, and I'd love to know what everyone's opinion is on this. There were about a half a dozen reasons not to do this case. I didn't need one more reason to not do this case, so we politely declined viability testing. And I think more to the point, there was reasonable thickness to everything. Nothing was completely thinned out, and so we went ahead and moved forward with this. So really kind of limited a little bit in terms of the absence of mechanical circulatory support. We kind of spitballed options for bailing out, and decided to just do this without support. 625 Pinnacle goes up. She got loaded with prasugrel. She's on unfractionated heparin, and you could see the CTO being traversed. It looked, I was hopeful that there was a little bit of a channel there. There was not really a channel, but we were able to get through it, switching back and forth between wires. And we went ahead and fixed the LAD with, I think, a pretty reasonable technical result, overlapping stents, all IVUS optimized and so forth. The broader strategy is to just sort of exclude the left main for right now. Her GFR, I may have mentioned, was about 28. So we're really kind of limited in terms of the amount of contrast that we can use for any one intervention. And so, while it's tempting to sort of fix the left main as the highest yield lesion, I think you're all in at that point. So we fixed the LAD and brought her back 2 weeks later, confirmed that she had no contrast nephropathy, no AKI, and so here's the circ intervention and the left main intervention as a second sitting. As just sort of a surrogate of how friable her vasculature was, my fellow got ultrasound-guided micropuncture access, ended up in a subintimal plane, and we watched, for the first time I've ever seen this, we watched the CFA, an intramural hematoma, just start to expand in the CFA, just with probing around with a micropuncture wire. And I think it's probably impaired tissue integrity from her years of steroids. So here's the circ stent going in that with high pressure dilatation looks good, and then we turned our attention to the left main. This is where it got a little bit tricky because there's no way to fix this without calcium modification, which means occluding everything for a little while. So we did 5 pulses at a time. We let her systolic pressure drift down to about 60, 70, gave a little bit of fennel, touched her up, and then did it again. So it was a very long time to deliver 120 pulses with blood pressure recovery in between, but got full expansion of our IVL, and on post-IVL IVUS, you can see some nice calcium fractures that weren't there before, and so we felt good about proceeding with a single stent all the way into the CTO segment, or what was previously CTO'd, jailing the circumflex. As you can see here, everything optimized, and good technical result, really good technical result. Both cases done with about 50 to 75 cc's of contrast, so felt pretty good about that. But here's the punchline. I just saw her in clinic last week, and this is her echo. She looks and feels absolutely fantastic, and this is about 2 months after the second PCI. So this was read as 62%. I'm not sure it's 62%, but it's a whole lot better than what she came in with. So the take-home messages here, I think, is that coronary revascularization in selected patients, I think, is the low-hanging fruit. I think we miss a lot of these patients, for one reason or another, we don't think there's viability. I just had a conversation with a colleague across town, sort of talking me out of fixing an LAD in somebody that has only partial reversibility, and but he's had some heart failure hospitalization. So I think, for me as an interventionalist, being undeterred by that sort of stuff is an important take home, and then just sort of navigating around all the landmines that were sort of specific to this case. Thanks so much.
This is an awesome case. I have a lot of questions. So question number one, was this before or after revived? This, revascularization, ischemic cardiomyopathy, that showed no benefit of revascularization versus optimal medical therapy. That's question number one. Question number two is, I personally, in a non-dilated LV with left main disease, I don't think we have data on viability testing, but Dr. Yulston, I can see him, he taught me everything about viability in the back, so I can't speak much about that, but with left main disease, I'm reluctant to do viability anyways.
Yeah, this case was done as sort of a three-part. The diagnostic was done by one of my partners, and then we did her second intervention a couple of months ago, so it was relatively recent. Viability, I think, is in our institution. It really depends on who you ask. I have kind of gotten away from routinely using that as the dividing line. I think, viability testing for revascularization increasingly is being used at our institution really just for the CTOs. Is the juice worth the squeeze? This is going to be a very complex CTO. This was relatively straightforward, fortunately, but we're going to spend a lot of time and equipment and effort on this and risk. Is that segment going to actually come back, as opposed to global ischemia? How much of this is going to actually come back? But bouncing in and out of the hospital, still wants to live. Bouncing in and out of the hospital with heart failure, combination of heart failure and non-STEMIs, felt admittedly non-scientific, but felt obligated to try to go for broke.
Great case. In fact, great session. Lots of success cases that we've discussed. You're at the University of Chicago. You're well equipped to take care of a failure if this didn't go as planned. So what would you say to the audience? Or there's two of us on this stage that I work at a university institution but don't have transplant VAD at my disposal. What was all the nuance that got left out of this case in terms of planning for that failure situation?
Yeah, I think that's completely fair. I picked this case because we really didn't have a safety net underneath us. The surgeons, who are incredible operators and collaborators, they're very friendly to us, bail us out of all kinds of things. We're kind of like, look, this is a suicide mission if we go into the OR. So it's you guys or nothing, and if you say nothing, then we should get HVC's palliative care involved for this lady. So that was it was sort of a hard stop there. But I think case planning in terms of mechanical circulatory support, and ideally, if there's any way forward for that, upfront is better than bailout. But we said, look, we may end up ripping up the iliofemoral system, and hopefully we don't rupture it. We'll have to stent the whole thing on the way out. That's going to be our bailout.
So to be clear, you had that plan in place. You had an advanced heart failure team involved in that. Yeah.
That's a tough case, Bet. Without use of Impella or maybe axillary involvement of Impella. For you, again, I harped on being in the community situation. You have 10 different groups, 20 different interventional cardiologists. Everyone's envious of what's happening, and M&M is once a month. So, you're doing a case which is extremely complex. I would argue, I'm not sure the left main was significant enough. I would like to see interrogation of IVUS or FFR for that. A long segment stent in the mid-LAD, but large epicardial collaterals to the SIR probably is what helped to improvement of hibernating myocardium. To the point of viability, we have the STITCH trial, which I believe did not, if I'm not mistaken, that didn't really demonstrate that if you determine viability or yes or no would make a difference in revascular CF. But I guess the point would be is, and I'm going to play just devil's advocate because I think I would have done the same thing for you, the same thing in your situation, although I would have pressed to do the Impella, and I would have probably ballooned that
calcified aorta, and I would have taken, peel away sheath and done the procedure, or I've done axillary, whichever. Only because if you had distal no reflow for the calcium, you'd be stuck, and that seems like the last remaining vessel per se that's open. But nevertheless, she probably has pulmonary cachexia. She probably has type 2 non-STEMIs. And our EP colleagues always say, I'm not going to place an ICD and an EF of less than 30% if the life expectancy is less than 1 year. But we're at this interventional conference, and these are the types of things when we're talking about heart failure interventional, these are the crossroads where you have this discussion piece. And, I was going to ask you one last question. I totally lost my train of thought. Oh, yes. How long did it take the EF to recover?
2 months.
Okay.
So, I mean, sometime in the last 2 months. We did this in April, May. So left main was significant both by IFR and MLA.
Okay.
So MLA was like 4, and IFR was very significant past the circ, but dragging the IFR wire back, still significant past the left main.
Fair enough.
So all that was confirmed. I mean, we want all the data. It's a completely fair critique, I think. But, we want all the data going in and really just kind of fix what actually matters as opposed to what's going to make for a pretty picture afterwards.
Yeah, what was the reason not to fix a left main before you fix the LAD? LAD was having collateral circulation.
Yeah.
And in this effort, if the left main goes bad, so we'll be in big trouble.
Yeah, I mean, I think that's always in our back pocket to fix it. The problem with fixing the left main without converting this into a fairly elaborate, 2-stent technique is you're jailing off the circumflex. So the plan, we kind of rolled the plan around, which to fix first, but fixing the left main means jailing the circumflex because the disease is sort of contiguous with the LAD.
Sandeep, one last question. So have you ever done MCS support, percutaneous, and then done an antegrade limb bypass in order to perfuse the limb if you're worried about ischemia during a PCI and then close up on the way out?
Yeah, we have. We've done that a handful of times. We've also gone up and over and slaved, sheets off the other side. Here I think the issue is that the vessel is just small, and it's not that she's on vasoactives and it's vasoconstricted. It's just really small and really diseased. So, both from an antegrade perfusion perspective as well as tearing it up on the retrograde side of it, we were a little bit concerned.
Thank you so much. Another great case. Let's proceed to our final case for this session, presented by Jason Bartos, University of Minnesota, VA-ECMO in heart failure with reduced ejection fraction and lung injury.
Yeah, thank you so much for having me, and thanks for the invitation. I am not a heart failure doctor. I'm a critical care cardiologist and interventional cardiologist, and we'll be coming to this from that perspective, but look forward to hearing your thoughts from the heart failure side. My disclosures are our federal funding and some philanthropic dollars from the Helmsley Foundation for our mobile ECMO program. So the case that I chose is a 36-year-old gentleman, no relevant cardiac history. He was at work and complained of chest pain for a few seconds and then collapsed. His coworkers rushed to his aid, activated EMS, and also had an AED on site and gave him 2 shocks, which were completely ineffective. EMS arrived 4 minutes later. They gave him 5 more shocks, transported him to us. In our community, we have a predefined protocol for these types of patients through our mobile ECMO program, and they rendezvoused with our team at one of our mobile cannulation sites. So we cannulated him after 82 minutes of CPR. We're supposed to be getting to people within about 50 to 60, but he was from further away. But due to age and the shockable rhythm, they were very optimistic and they drove further. So at 82 minutes, we had him on pump, about 8 minutes after he arrived in the emergency department. We used 25 French venous cannula, 17 French arterial, both on the right side of the groin. And the angiogram shown there, pretty classic for our patient population, occluded LAD, 1 stent, fixed. After cannulation, they go straight to the cath lab. The cannulation is shown on the CT scan on the right lower, and I show this because it's important for discussion later, and that our venous cannula goes all the way from the groin to the SVC. So we are very effectively unloading the heart with our VA-ECMO circuit, and I'll show you some data for that too. But everything uneventful up to this point. For those of you who don't use ECMO every day, this of course is schematic for femoral VA-ECMO. Of course, ultrasound guidance is really important for these large bore access cases, and we use fluoro to confirm. Even in the emergency departments with our mobile cases, we have C-arms that we use for fluoro confirmation, so we can do everything as safely as possible. Again, we use those 15 to 17 French arterial cannulas and a 25 French venous. We tend to use the CardioHelp system, but of course you could use any of your ECMO systems that are available. And a picture of what our typical groin looks like in the upper right there with a distal perfusion cannula for everyone. So he also had an 8 French distal perfusion sheath placed along with the arterial and venous cannula on the same side for speed. This, of course, is a case of HFrEF in lung injury, and of course I'm choosing a very severe case of HFrEF and very acute case of HFrEF given his lack of history, but the lung injury was also very severe. And it was noted he had a lot of aspiration on arrival of EMS. On admission, his CT there on the left shows this right upper lobe consolidation, which after bronch actually cleared up pretty well, but then after 8 days of hospital admission, it's actually shifted sides, and now the left side looks horrible, and really is in profound ARDS at that point. I show some characteristics of his support here because it gives us a sense of where we're going. So the VA-ECMO on admission, he's flowing 4.8 liters through those cannulas. He's got a blood pressure that has a decent map of 67, but he's got limited pulsatility. We do use balloon pumps with our ECMO circuits if we have less than 10 millimeters of mercury pulsatility, and he just scooted past that, so he did not get a balloon pump. He had no other devices other than the ECMO placed at the time of his cannulation. His FiO2 on the ventilator at that point is 60%, and on the ECMO circuit it's 50%, but the right radial artery ABG matches almost exactly the post-oxygenator ABG from the circuit. So really the blood that we're seeing in his right radial is essentially blood coming from the ECMO circuit at that point with limited pulsatility and limited forward flow. On hospital day 8, things have changed quite a bit. The ECMO flow is still pretty high, 3.5 liters per minute. His blood pressures are better. He has more pulsatility, substantially more pulsatility, but now his FiO2 requirements have increased substantially, commensurate with that CT scan. So his FiO2 now on the ventilator is 100%, and his ECMO is 50%. His right radial ABG hypoxic, his post-oxygenary ABG completely fine, just about the same as it was initially. But now that right radial blood is very much different, coming through his pulmonary circulation and his heart. Why is that? Cardiac recovery. So now he started on admission with this ejection fraction with a 4.8 liters of flow, and he had substantial recovery by day 8. And this is pretty typical timeline for our patients. Really that first week is a large amount of recovery. Unfortunately, the lung injury does not recover, and of course in him actually worsened a bit over that time. So what we're seeing is profound north-south syndrome. And this is a computer model using an aorta from a CT scan of one of our patients a few years ago to just show how little flow it actually takes to achieve hypoxia if you do not have good oxygenation through the pulmonary circulation. It really takes very little forward flow to cause problems in terms of your systemic oxygenation, especially the cerebral oxygenation, because of course the proximity of those great vessels. So it really is a big issue that we have to deal with. And the treatment for this, again, a HFrEF patient with poor lung function at this point is really multifold. So we start by increasing our ventilator support, using all the tools we have in our critical care armamentarium and the respiratory support, treating the ARDS. We treat the underlying lung disease, so bronchoscopy again helped initially, but was not as helpful with the ARDS, all the other treatments that you're familiar with. After that, we start to get a little bit more creative, so we suppress transpulmonary flow by increasing our ECMO flows as much as possible, unloading and bypassing the heart with every ounce of blood we can, really optimizing the oxygenated flow systemically. And then in the short term, we may also use negative inotropes to try to suppress that function while we bridge ourselves to another treatment. In the end, we usually end up bridging to VA-ECMO with another additional venous cannula, usually placed in the IJ, and then central ECMO if we're really in a tight spot. This is that data showing LV unloading with our ECMO circuits, again, as we cannulate them, so I'll accept the caveats there, and also that these are primarily, though in this data, not exclusively ECPR patients, so biventricular failure by definition. But in these 20 patients, you can see as we have the higher flows, we actually have lower LVEDPs and left and ventricular volumes. And you can see our pressure volume loops that actually shift substantially with the higher flows with more unloading and really no change in afterload because we are modifying our pressure requirements to maintain our systemic pressures roughly the same throughout these entire studies. So at this point, their pressures are the same at each flow level in the systemic or aortic circulation, but the fluid states are very different. And again, I mentioned the alternative cannulation strategy, the VA-ECMO option. With one simple cannula and a Y connector in our ECMO circuit, we can provide essentially oxygenated flow to the right side. We do have to balance out the flows, but when we're flowing as well as we were in this case, we have enough to spare where we can provide some back to the venous circulation while we also still provide some systemic circulation. And then central VA ECMO if we have to. So his case actually demonstrates a pretty typical course in this sort of situation. So we cannulated on hospital day 10 for VA ECMO. We were able to then bridge him off of the VA ECMO entirely, take out the arterial cannula on day 12 and just leave him on VV. Then he was trached on day 14. The VV ECMO was removed on day 22. And was awakened following commands on day 26, another point when these, again, 82 minutes of CPR, it takes a while to wake up from that. And keeping the team and the family on board with waiting is a challenge. But day 26, waking up following commands. Day 34, leaves the hospital, goes to rehab, and 3 months later is actually back at work, thanking his colleagues for the good work they did at his workplace where he makes furniture. So some take-home points. So the combination of cardiac and respiratory failure is supportable, but it evolves over time and we have to evolve with it. It's not a one-time solution, then move on. And so we have to be able to provide multiple modalities over the time course of that recovery. Refractory arrest, even after 82 minutes of CPR, is survivable, although time is an important factor, but he did very well. And north-south syndrome is common in these combined failure situations, and so we have to be able to think creatively and escalate as we need to for both forms of support. Thank you all, and happy to take questions.
Thank you very much. We have a few minutes because we're going to break, but I have a lot of questions about this. Number one, congrats, 80 minutes of CPR and the patient's neuro intact. I mean, that's unheard of. So, number one, do you use, in prolonged CPR, do you use pH prior to cannulation in your decision tree to cannulate or not cannulate? That's number one. Number two, you mentioned that in this case, you, the VA ECMO is unloading the ventricle. There's a lot of data about VA ECMO use in this scenario, and a couple of randomized clinical trials last year that showed no benefit. Unloading shows no benefit in terms of outcomes, but in other studies from Germany, for example, the timing of impella placement in VA ECMO patients pre or a few hours post actually shows some survival benefit. So how do you use all of that in your decision making of in this patient where you're aiming for recovery so that you give the patient the maximum chance?
Yeah, great questions all. So to your first point, pH is complicated because the CO2 and lactate in these situations are both contributing. So we do not use CO2. We do have a lactic acid criteria, 18 or less for inclusion. I didn't go through all of our inclusion criteria, but they theoretically are within 30-minute drive time. They're shockable, presenting rhythm is ages 18 to 75. And then when they get to us, we get a blood gas, and that lactate and a PaO2 are the two criteria that we use. The third one is end-tidal CO2, but nobody's ever screened out by that point because of an end-tidal CO2, because they're hypoventilated generally by that time. So the end-tidal CO2s are always high enough. But the PaO2 of 50 or greater and a lactate of 18 or less are what are required for inclusion. So pH did not factor in, but actually he was reasonably well ventilated and oxygenated during that 82 minutes, which is probably why he was one of those who did well. So I do think that they deserve credit for that for sure. To your second point, the unloading. So this is obviously a controversial topic, which is why I put it in there. I think for our patients, the #1 cause of death is neurologic. So 75% of our people who will die are dying of neurologic issues, not cardiac. Of our 600 or so patients now, 200 to 250 survivors, we've had 2 people need VADs and 1 person get a transplant. And so if you look at the cardiac recovery, it's almost universal. That's with our criteria. And again, our criteria are if you have 10 millimeters of mercury pulsatility or more, you get a balloon pump. We do not use Impellas in any of our patients. And the reason we've tried to limit the use is the vascular complications. The concern for need for blood and for the effects of an ischemic limb on an already so tenuous patient are potentially life-ending. And when it comes to family considerations, again, we're leaving them waiting with hope, but with worry for 26 days until they're waking up. You factor in an ischemic leg in that situation, and it's even worse. So I think for us, we've avoided the complications associated with that, and we've done okay. Cardiac recovery seems not to be an issue, but I think part of it, again, I sort of accentuated our cannulation scheme here in that we are not leaving the entire upper body worth of blood going through the heart. We are trying to drain the entire supply into our ECMO circuit. And I think that probably contributes the most to that unloading effect that we see with the VA ECMO itself.
One last question before I open up the audience. Do you use body surface area to determine venous cannula size in those patients?
Good question. We don't. We generally just use the same size for everybody. I think this goes back to sort of how you protocolize for a patient who's coming in with ongoing CPR. We really try to make all of our decisions before the patient ever arrives. And so we're deciding the arterial cannula. We have the 2 options that we will determine based on size of the vessels when we look at ultrasound. If we're really concerned that they're small, we'll shift down to the 15 French. Otherwise, we try to default to the 17. But the 25 French venous is good enough for us to get 4 liters of flow in the vast majority of people.
Okay.
So you've been flowing like 4 liters through 25. I believe your RV is unloaded, but I doubt about the LV when you're pushing back like 4 liters. And probably some of the issues that this gentleman developed is because of constant elevated wedge. What are your strategies in those cases, even though if they have minimal pulsatility?
Yeah, so it's a good question. So we have measured, not in every patient, but we do measure the hemodynamics in our folks, and we do not have markedly elevated wedges. In fact, like I showed in that data, when we turn up the flow, we actually have less fluid or less blood in the left ventricle, less pressure and less volume. And so what we see is actually counter to what you think. Now, we do use the balloon pumps again in people with very low pulsatility, so that may provide some small amount of unloading in a situation where we have very little right to left flow. And I think what you're pointing out in terms of the RV is important in that we're in a patient with biventricular failure because of their cardiac arrest, we're unloading their RV and I think preventing that right to left flow, which is hopefully working in our favor. We don't actually see a lot of easily reversible pulmonary edema in these folks. And this situation with the massive aspiration is definitely something that we do see with the 80, well, it wasn't 82 minutes of uncontrolled airway, but a good chunk of that was uncontrollable before there was intubation. And so, we do have aspiration as a profound portion of our patients having a complication related to that.
I believe you use like long protective measures on your vent, and what is your threshold to convert to VAV sooner rather than waiting to see the oxygen or PO2 start drifting and you will have like chest X-ray like that?
Yeah, no, that's a great point. So, and I think that's a point that I hope to accentuate, maybe I didn't say it enough, which is that is absolutely true. Like one of the benefits of VA-ECMO is that it allows you to maintain the lung protective ventilation, prevent the complications of high vent settings. And so for us, we can make that transition. We don't have a set protocol for when we switch. However, when we're getting to the 70-80% FiO2s is when we start to talk about it. So we're ready, if we do get, in this case, to 100%, we're ready to go on, and there isn't a period of decompensation where we're dealing with worsening issues. But we don't wait for the 100% to initiate it. Still, even with that, and with the aspiration I mentioned, it's less than 10-15% of our patients that end up with VAV. Most of the people do turn around before you get to that point, but it is a nice available modality for that situation.
Thank you very much. We're a little bit over the time, so we want to give you still a chance to have a cup of coffee in between sessions. This concludes our morning session. Thanks the panelists, thanks the presenters, and thank you all.